Good afternoon. My name is Tony Danuzzo. I'm with the Seeley Center on Aging. Many of you here know me. There's going to be people from other sites that we're teleconferencing to that will get to know me and other people. But thank you for coming out for this first lecture in a series of lectures that we're having for the East Texas Geriatric Education Center. This is in basic geriatrics and gerontology, but that doesn't mean you have to have advanced geriatric training and not feel that you can be here. This will benefit anyone who has an interest in geriatrics. This is a 3-hour session running from 12 until 3. And we have, this is on introduction of aging, and we have an agenda that is in your handout, if you got one of these. And basically this is how we're going to set it up in terms of the timing on things, and so we can get through different activities and different parts of lectures that we have set up. And okay, we have a lecture series set up for the whole year. Each month we're going to have different topics that are pretty general, and these are going to be part of other activities that we're going to have, mostly that are going to be online, part of our program in basic geriatrics and gerontology for the ETGEC program for healthcare providers and faculty who teach in healthcare professions. You can see next month, for example, we're going to have a lecture on June 9th on interdisciplinary teamwork. August is geriatric assessment. These first 6 months basically set up to be more along the geriatric medical side of things, and each one basically follows the next. So what we do in geriatric assessment will have a lot to do with what was done in interdisciplinary teamwork, and so on. The next 6 months, beginning in December, cover topics that may be considered more along the lines of gerontology and are still medical, healthcare types of things, but more general topics in gerontology. And don't worry about those funny little noises. That is, we're teleconferencing to other sites, and they are trying to hook up for whatever reasons, maybe the weather. There might be some noises that we'll have to just go with, and this is our first time doing this, so we're going to probably come in with some problems and work it out as we go. Hopefully it won't be too distracting. But we are teleconferencing to Lamar University in Beaumont, Stephen F. Austin University in Nacogdoches, Sam Houston State University in Huntsville, and University of Texas Health Center at Tyler in Tyler. They have been notified and given all the materials and everything that they may need to participate in this. Unfortunately, we're having a signal problem with Sam Houston State and Tyler, so they may come up at any moment. But right now, we are hooked up to Lamar University and Stephen F. Austin. This program is offering free CME credits for MDs, DOs, nurse practitioners, and PAs. For the entire session, it's 2.75 hours, and that basically gives you a quick rundown of what you'll need to do to obtain those credit hours. There are evaluation forms, one for each lecture, one for Dr. Goodwin's lecture, and one for Dr. Papa Constantino's lecture. Okay? If you stay for the full 3 hours, you get 2.75 credit hours. You just need to hand these in and sign the sign-in sheet, which I hope everybody did anyway. Okay? And if you can't stay for both, it's okay. If you can only stay for one lecture, you can get credit for that one lecture if you hand in the evaluation form. You can hand it in to me, you can hand it in to Beth Schilling, you could fax it to us, you could put it in campus mail to us. The main thing is, though, that this is looked at, this entire 12 months is looked at as a series of one activity, with each month having a certain lecture that we have scheduled for the second Friday of each month. At the end of the year, in May 2005, we're going to have a list of the evaluation forms and everything that you attended if you want to apply for CME credits. You hand in then a letter of credit, and then you'll be awarded those credit hours that you attended for each month. a little convoluted, but it is one way that we can do the CME for a whole year's activity. Okay? And I'll be happy to answer questions about this if you need to. If you really want to know the right answers, you might want to contact the Office of Continuing Education. That's their fax number and their phone, or you can contact us at our website for the ETGEC website. If anybody wants to write that down, that's fine, or I can give that to you later. We're also offering CNE for RNs, for registered nurses. Again, this is free CNE, 2.7 hours for the 3 hour of credit. And verification of participation is a little different. To obtain those 2.7 hours, you have to stay for the full 3 hour session. There's no partial credit if you only stay for half. And there is a packet for the CNE that explains on what to do with the evaluation form for the entire session. This has to be handed in at the end of the session to one of us for you to obtain the credit. Okay, it can't be mailed in. Yes?
Are you showing things on the PowerPoint slide that we can't see? It looks like you're looking at the PowerPoint or something.
Well, I'm mostly going over the evaluation forms for the CNE. Let me show you.
Okay.
Yeah, Kelly, this is what we had with the agenda,
Okay.
the lecture series, topics, teleconferencing sites, the CME credit procedure to obtain CME credits, contact information, and the CNE. Okay. And I need to say that both of our speakers today, Dr. James Goodwin and Dr. John Constantino, have no commercial affiliation to disclose.
Tony, we have a question from UT Health Center.
Okay.
Does the CNE also apply to LVNs?
No, RNs only. Linda, do you want me to back up with some of the information in terms of who you can contact?
No, I think we're fine. Thanks.
Great. Okay. One thing about all this is that it's going to be very interactive. There will be voices coming from all over. And this is new for us, and we're going to be learning as we go. And each time, I think it'll be streamlined, and we're going to really get all the parts of it down. But I really thank everybody who's been participating and helping with this. The AHEC coordinator has been great. Ingrid Bowden as the project coordinator. Beth Schilling has been really helpful on things. And it's just been a real team effort for everybody, and I appreciate everybody's participation and their patience for getting through this today. We have two speakers, as I said. Dr. James Goodwin is our first speaker, who's going to be talking Introduction of Aging, New Models of Care for the Aging Population. Dr. Goodwin received his medical degree from Harvard University in 1971 and his residency in internal medicine and fellowship in internal medicine in 1978. He established a geriatric division at the University of New Mexico in 1980. In 1985, moved to Wisconsin as vice chairman of medicine at the Medical College of Wisconsin. Since 1992, he has been chief of geriatrics and director of the Seeley Center on Aging at UTMB, has published over 200 peer-reviewed articles, and his research background is in immunology, nutrition, outcomes analyses, nutrition, health, minority health, and assessment of functional status among older adults. He is what may be considered our keynote speaker for kicking this off as our first lecture and talking about introduction of aging, new models of care for the aging population. Dr. Goodwin?
Well, I'll try. Okay, so Tony said this is basic, and then he said, but there would be something for people who are beyond basic. Nah, no, This is basic. This is basic gerontology. The messages Obviously, Introduction to Aging has about 300 potential hours of talks, of which I will take maybe 10 or 12. So I'm just selecting a few messages. One is, and I'm just telling you at the beginning, and then we'll be going over it. One of is there's a lot of old people. Second one is there's going to be a lot more. Third is just to go over the reasons why there's been this rapid growth in elderly in this country and why there will continue to be a rapid growth. The fourth, which is really getting into the bulk of my talk, is that old people are different than other people. And I'll get into what I mean by old and quibble about that stuff later. But that old people are different than the rest of us. And to the extent that we don't realize that, it creates problems. To the extent that we approach an older individual with the same sort of rules or mindset that we approach, say, someone who's 62, we can get into trouble. We can get into trouble with over-treatment. We can get into trouble with over-diagnosis, issues like that. And I'll be going into several examples. I'll just give you, I'll give you at least two examples where probably most of the people, at least not most of the people here, but most of the people at the other sites would not have had any idea that, oh golly, old people really are different for those examples. I think that in general what I'm going to be getting to is some of the major concepts that we have in medicine and in nursing don't work that well for old people. Let me take the most basic, the concept of disease. Really, the whole concept of disease, how we think about disease, really breaks down when we're talking about people in their 80s and 90s. And even though we still use it, sometimes we get into trouble because we use it. And if I could just take an eraser and wipe away the concept of disease, the whole concept that's been grown up over the last couple centuries, when we're dealing with older people, I think we'd be better off. And finally then, I'll be talking a little about alternative models, other ways of looking at optimal care of older individuals. There won't be a lot of answers here. You know, one of the wonderful comforting things about modern science is that there's an answer for everything. We can explain everything. Can't predict anything, but we can explain everything. And everything is like, here's exactly why this happened. We fool ourselves with that, but we're comforted by that. And while I'm going to be taking away some of the comfortable ways we have of understanding older people, I'm not going to be replacing them with other comfortable ways. I'm not going to say, hey, while the disease concept doesn't work, here's a wonderful new model that will make you every bit as comfortable, because we really don't have it. And so the overall message of dealing with people in their 80s and 90s is often each person is new, each person has to be struggled with, the problems of that person has to be struggled with in terms of how we optimally deal with it. Okay, so there's a population pyramid. And what this is three time periods, 1975, 2000, which is essentially today, and then projected ahead 25 years. And the way this population pyramid is constructed is you just take, I think in this pyramid the boys are blue and the girls are pink, yeah. And so you just take all the males in this country between the ages of 0 and 5, and you say how many there are, and that's how big this bar is. And that's about close to 4 million. And then there's about close to 4 million girls that in 1975 were between the ages of 0 and 5. And then the next bar is how many were between 5 and 10, and then between 10 and 15, and on up all till you get to people between 75 and 80 and over 80. And this is the way it looked in 1975, and this is the way it looks today, and this is the way it looks is going to look in 25 years projected. Well, you can see what's happening to this population pyramid. what's this here? These are the baby boomers, right? And the baby boomers are sort of, in other words, like in 1975, the baby boom generation started in 1945. So in 1975, the baby boomers were just about 30 years old, and that's when, that's when this this increase in this bulge here, and then it goes down again. And then this, in about 1965 and in 1955, is when everyone was saying, oh my God, we need huge departments of pediatrics because we have this incredible growth. That's when this bulge was a little further down. Now it's sort of, I don't know, this sort of looks like a middle-aged person with weight problems, perhaps, the 1975 sort of falling mass. And then in 2000, this bulge here is working its way through. It's sort of like a boa constrictor who swallows a pig, and the pig being the baby boomers, and then it sort of worked itself up. And what you see is a rectangularization of the population pyramid. So it's not a pyramid, and by 2025 it really won't be a pyramid. It becomes I'm lost for geometric shapes today. A what? A rectangle? It becomes a rectangle. And so what happens then is, just because of this growth in baby boomers who are working their way up, we are about to see this huge growth in elderly. Whether you call elderly people over 65 or 75 or 85, there's going to be this huge growth because this huge ballooning population is getting older. And that's why when people talk about Social Security going broke or retirement plans going broke, they can speak with a certain degree of confidence, barring some change in funding, because these people are already with us. I'm one of them, and if all things go well, I will be one of these people out here in 22 or 21 years. Now, so that's one reason there's this huge increase, and we talk about the fact that there's currently about 1 out of every 12 of us is over 65. I'm sorry, about 12% of us is, 1 out of every 8 of us is over 65, and it's going to 1 out of every 5. It's going to about 20%, 22%. There are some countries that are already there. Italy, I think, is at about 19% population over 65. Some of the Western European countries. Japan has a very high percentage. We can look at them and see, the way we are going to be in a couple decades. So one reason there's this huge growth is that this population bulge is working its way through. The other reason is that we're all living longer. And this is a much more interesting reason, and a much more sort of optimistic reason. And that's shown on a fairly complicated next slide. And this is a slide of, as you see, this goes from 1840 on up to the present, and then projected. But this is what was the actual life expectancy of the best country in the world at that time. So, in other words, in 1840, there weren't that many countries that had good data on life expectancy. The Scandinavian countries did, some of the English-speaking countries did. And they're just looking around in 1840 and says, well, all the countries for which we have data, which country has the longest life expectancy? And then you plot that life expectancy on this graph. Now, life expectancy is just how long does it take for half a population to die? So life expectancy at birth today is, if we take 1 million people who were born today, how many years is it going to take for half of those people to die? That's the average life expectancy. And what you can see here in 1840, of the best developed country in the country in the world, life expectancy was 45 years. So babies born in 1840 in that country, half of them had died by age 45, and that's not including deaths in the first year. because they weren't including early childhood deaths in these calculations. And then what you see is that there's this steady growth in life expectancy over the next 160 years. And the really interesting thing about this growth is that it's linear. Every decade, life expectancy in the world has increased by between 2 and 3 years. So every decade, people are living 2 to 3 years longer on average than they were the decade before. Now that's an amazingly fast increase in life expectancy. When I was in medical school, which was back here sometime around late 1960s, we knew this was happening, but we thought it was all over because most of the increase in life expectancy was because of all these increases in public health that had decreased childhood mortality, that had decreased mortality of women in childbirth, that had decreased young adult mortality, like the flu epidemic. So all these major increases, like vaccination and better nutrition, were working to decrease premature mortality. And so when you look at the initial increases here, all these increases, almost all the increases in life expectancy over the first 120 years here is by rapidly reducing premature mortality. And so when bodies would get together, when authoritative bodies would get together and say, well, what is maximum lifespan? What are we aiming for here? Because we're getting rid of premature mortality. What's going to be the goal then? Well, once we get rid of all disease, for example. And people would come up with estimates about what was the actual human lifespan. And so some people got together in 1930 in Dublin and said, well, the maximum human lifespan is 65 years. Well, we passed that one. And then they got together in Dublin a couple years later and said, well, let's do 70. And then we passed through that one. And then the UN, the United Nations and World Health Organization, started making estimates on what the maximum life expectancy is. And what you can see is this desperate scrambling to keep up with reality because it was growing so quickly that the UN and WHO had to say, okay, it's 75. No, wait, 78. No, 80, 85. And it just keeps on increasing and increasing and increasing our estimate of what maximum life expectancy is because we keep on living longer and longer and longer. And since 1960, this growth in life expectancy has been predominantly because of older people living longer. It hasn't been what the early increase in life expectancy was, which was getting rid of premature mortality. What we're doing now is we're improving post-mature health so that people are living longer and longer and longer. Now, the reason that matters is we have this thing where we say, okay, 65 plus is old, and geriatricians will do that because that means we're responsible for 30 million people. That makes us feel happy. But if you think about it, the reason we have so many older people is because we're living longer and longer and longer. Well, why are we living longer and longer and longer? I mean, there can only be one reason why people are living to 85 today rather than, say, 65 40 years ago. We're healthier, right? People are healthier. And so what it means is that we have to continually change our concept of what old is. Because the 75-year-old today looks like the 65-year-old 40 years ago. Is precisely the same. I mean, in terms of life expectancy and all that, since life expectancy has changed by 10 years in the past 40 years, then the 75-year-old looks physically, from a health perspective, every other way, like the 65-year-old. And so when we're thinking about, oh my God, in 2050 there's going to be 4 million centenarians, which some optimistic projections would say that by 2050 there might be 4 million centenarians and 1 out of every 100 people in the country is going to be over 100. People go, oh my God, and they picture what a centenarian looks like, what we have in our mind, what a centenarian looks like, and say there's going to be 4 million of those. That's going to be tough. But in 2050, the people who are 100 are going to look like people who are 85 today. and the people who are 85 are going to be looking like people who are 70 to 75 today. So there's this constant shift, and that matters with people like me because you go through medical education and you have a certain set view of things. You got to continually upgrade it, or you get into trouble. So typically geriatrics, if we had to make an age category, and we always grumble about anytime anyone forces us to make any category, but if we had to say, you know, what do we typically think of as old, we would normally be thinking about people over 75. Our clinic, for example, I discourage people under 75 from being seen in our clinic because the resources we do in terms of our multidisciplinary approach are best used in people who are 75 and older. But 40 years ago, that would have been people who were 65 and over, because they would have looked like the people. And 40 years from now, it's going to be people 85 and over. So just wait around. All right, now I will get into two astounding things that I bet you don't know. And the reason is I'm visiting that concept that I introduced the talk with, which is that the rules for old people don't, or the rules for young people don't always apply for old people, and if we apply them willy-nilly, we can get into trouble. Particularly once you get over 80, an awful lot of the concepts, the way we think about illness and disease, just don't work very well and often cause more harm than good. And so the example I'm giving you is a somewhat bizarre one because, and will probably be surprising, is blood pressure. Because if there's one success story in modern medicine and public health, it's blood pressure. Heart disease mortality has declined substantially over the last 40 years. Stroke mortality, I think, has been cut almost in half in the Western world over the past 40 years. And most people ascribe that mostly to good control of blood pressure. Also exercise, also lowering cholesterol, but mostly good control of blood pressure. So we all know that blood pressure is incredibly important, and it's the first thing we do when you go see a doctor. They take your blood pressure, and it's a nice little number, and we always obsess about it. Well, actually, in people over the age of 80 or 85, blood pressure has an entirely different meaning with respect to health. To put it simply, once you're over 85, the higher your blood pressure, the longer you live. Now, a lot of people are not going to want to hear that because it's confusing, you know, and they're going to start leafing back to the front of the book and say, where did this guy get educated? Who is he from? You know, because you don't want to be confused. You know, you've got this nice little thing that high blood pressure is bad for you, treating high blood pressure must be good for you. Well, that's the problem with dealing with old people. We have to get rid of a lot of our nice little things because they don't work very well. And I summarized a couple of studies here, but I should tell you that this has been studied in 6 different very good, very large studies. And every time it's studied, we find the same thing, which is the higher your blood pressure on entry, if you're over the age of 85, the longer you're going to live. Okay, so here are 2 studies. One from Leiden and one from Tampere. This is Finland and this is Holland, right? And what they did in both studies, these are actually pretty early studies from the 1980s, remarkably not publicized at all, where they went in and they did a population-based study. And a population-based study in this context means they went into town and they found everyone who was over the age of 85. It was not, you know, volunteers or anything. They took everyone in the towns and went and measured their blood pressure and then came back 5 years later and said, who's alive? So here is the systolic blood pressure level, and this is the percent alive 5 years later. So one thing you see, if we start with Leiden, we got as your blood pressure is higher at baseline, your chance of being alive 5 years later is also higher. So that if you have a 200 blood pressure, which would lead to hysteria in most clinics, and people telling them they ought to rush to the emergency room, 41% of those people were alive 5 years later, whereas if you have a nice happy 120 type blood pressure, your chance of being alive is only 25%. And if you have, low blood pressure, well, you better start making your funeral plans because you don't have a super high chance of being alive. Same type of intemperate, same type of population-based study, same type of relationship. The higher the blood pressure, the longer you live. Now, none of these numbers are splendid because we're talking about everyone over the age of 85, and one of the facts of people over 85 is they don't have that long to live. But basically, so one thing and by the way, it's the exact same relationship for diastolic blood pressure over here. As I said, there are 4 more studies showing exactly the same relationship. It doesn't matter whether you control for so-called comorbid illness, whether you control for whether they have other illnesses. It doesn't matter whether you control for whether they're on blood pressure medicines or not. You still find this relationship. The higher your blood pressure, the longer you live. Now, that doesn't address the question of whether we should treat high blood pressure in older people. Okay, I'll get to that in a second. But basically, at the very simplest, most fundamental fact, if you've got an 85-year-old person, your mother or your patient, oh my God, if I just ignore it, it'll probably go away. Okay. And that person has a blood pressure of 220 over 110, that's good news. All right? Try to grasp that for a second. Just try to grasp that. Okay? Don't just laugh it off. These are facts. If they have a blood pressure of 120 over 80, that's bad news. Now, do you imagine how hard it is to be a geriatrician then? Because what is burned into our frontal lobes is how important is blood pressure. Can you imagine how hard it is to talk to your colleagues? They think you're an idiot. Or explaining to daughters-in-law why you're not excited, why you're actually chuckling when you see a blood pressure of 190 over 110. Because it's good news. And you can't make it go away with any amount of reasoning or controls. So that's the challenge of geriatric. If the rule that high blood pressure is bad for you, if that doesn't work for the very elderly, what does? What should we, we have to challenge, we have to question everything we think we know about older people. We happen to know this for blood pressure because it was easy to measure and there were some good studies. There's a lot of things we don't know about older people that we need to worry about. Now, let me just go on because people will say, well, is it a good idea to treat high blood pressure in older people? And that's a more complex question. It's not complex in young people at all. And it's not complex in so-called young old people at all either. In other words, there's no doubt that a 75-year-old with high blood pressure should be treated. There's pretty much no doubt that someone in their late 70s should be treated. However, when you get over 80, there's doubt, and I will just share the doubt with you. This was spread the doubt. That's my role for today. This was a meta-analysis. A meta-analysis is when you combine several clinical trials because there's not enough data in any one trial to give you a result. You get the data from all the clinical trials and you combine it. And so these investigators did a meta-analysis of several clinical trials that included people over age 80 in treating high blood pressure. And in these trials, they had a control group that didn't get treated and they had a treatment group that did get treated. But each trial only had a few people over age 80, so there wasn't enough to look at the effect of age on treatment. But by combining all of them, they came up with something like 1,400 1,500 people. Okay, so by going to all these trials, they had 1,500 people who were in these controlled trials over the age of 80 with high blood pressure, typically blood pressure higher than 160 systolic. And then this is the ratio here, or the so-called relative risk, of having a bad outcome in a treatment group versus non-treatment group. So what you see here, and this, by the way, for comparison, is just a whole bunch of people, 15,000 people from these same trials that were over 60. Because all these trials were limited to people over the age of 60. these people over 80 are actually included in this group over 60. And so what you see is that if you're on treatment, if you get treatment for stroke, your chance of having a stroke, if you get treatment for blood pressure and you're over age 80, your chance of having a stroke is reduced by 1/3. That's good. Same if you're over 60. If your treatment of having a heart attack is reduced by about 15%, but not significantly. I mean, this may be not significantly different from 0, but it looks like a reduction. Here it's a bigger reduction, and it's significant. Cardiovascular death, interestingly enough, this is like, in other words, having a heart attack. But if you look at deaths, it's actually, you have a slightly higher chance of dying of a heart attack if you're on treatment. And then if you look at all deaths, which is here, actually, the treated group had a 14% higher death rate than the untreated group. And that was a statistically significant increase. So in other words, when you took all these studies, if there's one thing we know, it's treating high blood pressure is good for you, right? Well, actually, over the age of 80, it's a trade-off. If you're treated, from what we know, from so-called evidence-based medicine, looking at all these meta-analyses, when you treat someone over the age of 80 with high blood pressure, that person probably has a higher chance of dying over the next few years and a lower chance of having a stroke. Some people might take that trade-off, but the point is not to give you an answer on this or what do you do or questions like that. The point is to say, we don't know a whole we should not engage an 82-year-old with the assumption that we know necessarily all the rules or what's best. I will give you one other brief example. Chemotherapy. I do chemotherapy for breast cancer because it's sort of a trendy disease, and there's a lot of stuff on chemotherapy for breast cancer. And this was a headline from an oncology newspaper that said that chemotherapy, and there were headlines like this in the New York Times, and chemotherapy, essentially virtually all women with breast cancer ought to get chemotherapy. Well, that's not really true, because 40% of women with breast cancer are over 70. Okay, 40% of women with breast cancer are over 70. Oncology is a geriatric discipline. And if we take the headline, all women with breast cancer, you know, if you don't think, hey, there are these different women and they're older, you could just say, well, all women with breast cancer, that means just about everyone. Not really. This is another complicated slide, but this shows another meta-analysis where they took 40,000 women from all these trials who had received chemotherapy after breast cancer, and this vertical line here, this 1, means that chemotherapy had the same survival as non-chemotherapy. And anything down here means chemotherapy was better, and anything above the line means chemotherapy was worse in these various trials. But what this meta-analysis did then is it looked at these women as a function of age. So here are women under age 50 who received chemotherapy, who were premenopausal, and they had a big benefit. This goes down to about 0.6, 0.7. So that means that they had a 30 or 40% lower death rate from cancer by getting chemotherapy. So that's a real good reason to take it. And then when you go up to women 50 to 59, there was also a nice benefit. But then you go to women 60 to 69, the benefit gets less. And then you get to the women over 70, and the women over 70 had no benefit. All right? So 40% of women with breast cancer, once again from evidence-based medicine, probably shouldn't be getting chemotherapy because they're over age 70. Once again, we have to worry about age. There's a sort of a rather silly a view in gerontology sometimes that whatever is good for young people is good for old people, and if old people aren't getting it, that's evidence of ageism. That's evidence of bias against old people. Sometimes old people shouldn't get something because it's a real bad idea, and this would be one of those examples. Okay, let me go to, I'm going to spend the rest of my time talking about sort of different ways of thinking about the elderly. And to do that, I have to talk about some depressing news, which is that everyone dies, okay? One of the nice things about dealing with old people and being a geriatrician is that most of my patients know that. When I was a rheumatologist and took care of younger people, they didn't know it at all. I mean, they said they knew it, but it hadn't really been incorporated. But most old people are comfortable with the fact that everyone dies and that that's part of life. But it is important when we start thinking about issues like prevention. If we prevent all disease, we're still going to die. If you don't smoke and don't do all those other fun things in life, you're still going to die, all right? So I'm financed by the Tobacco Council, but the point is the fact that you are still going to die becomes more and more important the older you get. And this slide just shows that. This is normal life expectancy for women. The slide for men looks the same, but depressingly quite a bit lower. And so this is normal life expectancy for women. So this says 65-year-old women on average live another 19 years. If you're college educated, you can add 2 or 3 years to that. Various things. If you exercise, you can. If you smoke, you have to take away 2 or 3 years. But on average, 65-year-old women will live another 19, 20 years, and then that slowly goes down with age. Well, what happens if a 65-year-old woman gets a disease like bad congestive heart failure, say after a heart attack, and she develops a bad heart failure, and that has a 50% mortality over the next 5 years? What happens to her life expectancy? Well, a life expectancy normally would be about 19 years. If she gets a disease that has a 50% 5-year survival, the life expectancy goes down to about, guess what, 5 years, because she's got 50% 5-year survival. It's going to be about 5 years. And then you can look at, what is the effect of giving a woman various diseases at various ages. So what you have here is if a woman who's age 65 gets a disease with a 50% 5-year survival, that's removing about 15 years from her lifespan, and it's removing about 2/3 or 3/4 of the rest of her life. The older you get, the less the relative impact of a serious disease has on your lifespan. It always has an impact, but the older you get, the less the impact a serious disease has on your lifespan. And so we can't take the same set of attitudes that we might have about trying to find and prevent this disease in this group of people as we do in this group of people. If we do, we'll cause more harm than good. Doesn't mean we shouldn't have an attitude about finding and preventing it. It means if we have the same attitude, we could cause more harm than good. So when you give that same disease to an 85-year-old woman, you're reducing her life expectancy by about 3 years, and you're reducing her total life expectancy about 40%. So it's a difference between reducing life expectancy by 15 years by having that disease. And that means that every time we look for a disease in medicine, there is a cost involved. And I'm not talking about the financial cost, because that's another series of lectures. I'm talking about a cost to the person that we're looking for that disease. Every time you go to the doctor's office, there's a cost involved. There's a cost that they'll find something that you otherwise you wouldn't have needed to have found. There's a cost of the unpleasantness of being in a doctor's office. There's a cost that you'll get sent for a test, and maybe you'll have some terrible side effect of that test and die. And you can look at, these are small costs typically. In other words, in most situations, let's say we do screening for colorectal cancer. I won't ask for a show of hands as to who's actually had screening for colorectal cancer, but screening for colorectal cancer would be perhaps they'd look and see if you had blood in your bowel movements, and then pretty soon they're sticking up this huge tube up the wrong end and looking for cancer, all right? Now, that's a cost because about 1 out of every 10,000 people actually suffers a terrible complication of that. But the reasoning is, in a 50-year-old, that the benefit outweighs the cost. Because the benefit is when you occasionally, 1 out of every 1,000 times, you find a cancer that person would have died from if you hadn't found it early, that benefit outweighs the cost. Everyone following me on that? So what happens is, the older you get, the lower the benefit, the lower the potential benefit. Let me tell you a little story. Okay, so you've got this 45-year-old woman, and she goes in for her mammogram because she knows about the right thing to do. She goes in for a mammogram, and they find a lump, all right? And it's a small lump. It's 1 centimeter, 1.5 centimeter, and they biopsy, and it's cancer. And then she goes and she gets a lumpectomy, so it's taken out, and then she gets 6 weeks of irradiation, and then she gets chemotherapy, and all her hair falls out, and she's sick, but she finally recovers, and 6 months later, she's starting back on her life again. Everything's okay. And then as she's walking to work one day, she gets eaten by a lion, all right? Now, this is not necessarily from Galveston, but she gets eaten by a lion, okay? Or she's in an automobile accident on Interstate 45, more likely. Causeway. She stops on the causeway, okay? She dies, all right? Now, for that woman, mammography was a very bad idea. For that woman, not for women in general, not for public health, but for that woman. Because she had 6 months to live, and she would have been a heck of a lot better off in those 6 months to live if she hadn't been getting chemotherapy and operations and radiotherapy, right? But we don't know. So, we don't know whether you're going to get eaten by a lion or stop on the causeway, so we go ahead, right? But the older you get, the more lions there are, okay? The older you get, the more likely that something is going to knock you off anyway. And then what happens is, and it's criminal, really, it's immoral, when we apply the same rules for a 65-year-old or a 55-year-old, and we apply it to an 85-year-old, when the benefit becomes so much smaller, and yet all the detriment is at least as big, if not bigger. And so this is why we have, and there are very few data about this. This is why we need a lot of common sense, and we also need to educate our patients so that they can make their own decisions on some of these things. Because you wander into a colonoscopy, screening for cancer, there's a phrase in medicine that to a hammer everything looks like a nail. And we are specialized enough in medicine that if you wander into the wrong silo, you're going to get what they give. And so it really, there needs to be sort of active thinking and educating our patients about the fact that the benefits are less. It's hard because, you're talking to your patient, you're saying, I've got some pretty good news for you, you don't need the colonoscopy. It's because you're going to die soon. So it's a hard message to give to people, but it's very important that we think sensibly about this and not get swept up in this preventive medicine enthusiasm, which really doesn't make a lot of sense for our particular patient. Okay, one other concept I'll just touch briefly on then is the whole concept of disease doesn't make a lot of sense in the elderly, because the prevalence of problems in the elderly gets so high that you wind up with, by the time you're 85, you're going to have 9 diseases. And I don't understand how that helps that person to acquire all these diagnoses. In my experience as a geriatrician, people, and this is sort of anti-intellectual and backward and retrograde and all that stuff, but people who deal with aging like, well, yeah, I feel that way because because I'm old, they seem to do a lot better than people who have acquired 27 diagnoses. And let me just give you this one example of Alzheimer's disease, and I'm sure we'll get a talk later on about Alzheimer's disease, but the thing is that as we get older, we meet criteria for more and more diagnoses. 50% of people age 85 and above meet criteria for Alzheimer's disease. 100% of people over the age of 65 have arthritis. 80% of women over the age of 80 have hiatal hernia. How does that help us anymore? I mean, in other words, if an 85-year-old woman comes in and her stomach hurts, and I do a test, a barium swallow or an endoscopy, and I look, 80% of the time I'm going to turn to her and say, you have a hiatal hernia. I haven't explained why her stomach hurts. I knew she had a hiatal hernia. At least I knew she had an 80% chance. I haven't explained why her stomach hurts, because all these other 85-year-old women don't have stomach pain, and they have hiatal hernias too. So this diagnosis, it tricks us into thinking we know something that we don't know. And it also gets us away from dealing with life. It gets our patients away from dealing with life and more into sort of a medicalization. What the threat with older people, because they have so many problems, is they can get entirely medicalized. Now, there's a threat in the other direction, which is that serious problems can be overlooked. But in my experience as a physician, I see the consequences of over-medicalization of the elderly. And I don't have a solution for that. I'm just saying that that's a concern. Okay, let me get into a couple of more sort of overviews. What happens then with age is that physiologic function slowly declines. So you start with a given amount of physiologic function. Let's call this brain power. And you may start A, B, or C. And maybe in the first 30 years of your life or all through your life you can build up. You can go to college, you can play chess, Lord knows. And even when you're going down here and you're declining, because starting at age 30, all physiologic functions decline. Now, we can take a physiologic function like muscle power and suddenly start lifting weights, and you've been declining like this, and you go boop up there again. And then but you go back to this underlying decline. Starting at age 30, all physiologic functions that have been capable of being measured decline with age. Decline as a function of age, not just of disuse, which is true, but even if you have someone who's a marathoner and they're running 3 marathons a week and doing all the right things and popping vitamins and feeling good and all that stuff, okay, their physiologic functions will still decline over age. That's an inevitability of aging. What matters is what you start with, and you can influence the rate of decline with exercise or other interventions. But then what happens is, depending on where you start and depending on your rate and your interventions, you just decline in your physiologic function until you get to a place where it becomes symptomatic and someone says you have a disease. Now, that means, I think, that this person here doesn't have Alzheimer's and this person here does. And I don't see how that's very helpful. I think Alzheimer's is a very helpful concept when you're dealing with 65-year-olds, where it's very rare, or even people in their 70s. But when you're dealing with the very elderly and you have something so prevalent, calling something a disease, I just don't see how that helps us, helps them or us in dealing with the situation. So let me then just briefly review models. This is the model, this is the disease model. You got a healthy organism, a bad thing comes along, and you got a sick organism. Now this comes from the germ theory. This model has not been with us all that long. It's been with us since the late 19th century in the germ theory, and it works real well for germs. You come along, you got a polio germ coming in here, and you got someone with polio. You got a pneumonia germ here, you got something with pneumonia. And so tuberculosis, same thing. So the rule of the doctor is bad thing comes along, and then the doctor gets rid of the bad thing, and then things do better. Or it even works pretty well with cancer. You got a breast cancer, then the thing to do is to take it out, and you got a healthy organism again. However, many of the problems of elderly, there's no bad thing. There's thing. There's factors, okay? And this is more a concept of syndromes, where you have an organism and you got a factor, 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 and you got all these things interacting. And some of them are in the medical context, some of them are like what's happening in the family, some of them are, there's all sorts of different things. In the neighborhood, there could be all sorts of different factors, and the combination of those factors gives a person with a problem. And so then the goal of the team of the people caring about the elderly is not to diagnose the one thing wrong with that person and and fix it. It's to try to identify as many of these factors as possible, and then you can prevent the problem by dealing with them before you have a problem, or if you have a problem, you fix the ones you can. You can't fix them all. So here's for example, let's say the problem is falling. You have someone who's falling, and you have a 79-year-old woman, and she's falling. The reductionist model, sort of the disease-based model would be, well, she had a stroke. You know, she walks like this, so of course she falls. You know, she's weak on her right side. There's no doubt about it. And she has and that's it. Okay. The syndrome approach is, yeah, she had a stroke, but also she's got a little arthritis in her knees. And when we did a home safety eval, she has a throw rug, and she doesn't have anywhere near the quadriceps strength that she needs, you know, she has habits left over from the Depression where all the lights go off at night, and she's been that way for 50 years, and she's not about to change, so there's real poor lighting at night. She has decreased night vision, which interacts with the poor lighting. I mean, you get decreased, for those of you over 40, you know what decreased night vision is. I mean, it's like going into a theater in the day and you can't see anything. You know, you suddenly blam into someone. So that continues to get worse for, you know, a little optimistic aspect. And then she's got decreased proprioception, you know, so there's all these factors and they all contribute. Now, this is a much more optimistic model. Okay, it sounds like, oh, this is awful, but there's a bunch of things you can do here, right? And depending on your specialty out there, you know about those things. You know that you can give people some strengthening exercises. You can modify their home environment. The strengthening exercises would help the arthritis as well as you might, you know, do other things for the arthritis. With medications, you can certainly take care of this. So this is more of a syndrome type model. Here's another syndrome, delirium. What happens in the old model is you have someone who's out of their house, out of their mind, flailing around in the hospital, and someone comes in and does a mini-mental and they find they're demented. They say, well, they're demented. That's why they're delirious. What can you do? You know, brain ain't working, you know. But when you look, you say, no, there's all sorts of factors affecting, there they are, affecting this delirium. The fact that he came in with a little problem learning, a little delirium, a little dementia where he had difficulty learning new things, and then he got put in a new environment, and that interacts with the fact you can't learn new things, and so every time you wake up you don't know where you are and it's unfamiliar. And then he got given medicines, and he had pain because he broke his hip, and so the pain is going to contribute to the delirium. Then he got medicines for the pain, and that's going to contribute for the delirium. And those of you who take care of hospitalized patients know how incredibly difficult it is to know where to go here. You know, to know in a delirious patient whether they're not getting enough pain medicine, and that's why they're delirious, or whether they're getting too much pain medicine, that's why they're delirious. And it's one of the great struggles of taking care of older people in the hospital. Maybe he's hypoxic, maybe he has an infection. And so once again, you don't just say, hey, you know, what do you expect? There are things, and you can't necessarily do something about hospitalization, except create a wonderful ACE unit or something like that. But you can do stuff. You can remind the people. You can put things in the room, you know, saying where they are. You can put calendars, clocks. You can have a relative in the room to be a source of stability so that when they wake up they'll know where they are. So once again, the syndrome model helps. More models. Okay, 3 more minutes of models. Classic model, you have an organism like me, and you have a disease, and I die of it, you know, like breast cancer. And then the role of the doctor is to intervene with a mammogram, maybe, and prevent it from being bad, or something like that, or treating the high blood pressure, and then the person lives happily ever after. Often in older people, disease, what we call disease, is not really the cause of death. It's a manifestation of the fact that everything is falling apart. Once again, the happy message of geriatrics. And so, to the extent that we chase after some of these things, we can cause harm. When you have someone who is getting ready to die, sometimes things happen. And what you have to really what you really have to focus on is what is a problem? What is the actual problem? What is harming this individual person? What is making them uncomfortable? That's what I have to deal with. And so the older we get, the fewer potential problems there are. Here's our preventive medicine model, which works very well for 30, 40, 50, 60, 70-year-olds, where you've got this person chugging along doing fine, and there are potential problems out there, potential bad things like high blood pressure. High blood pressure doesn't, by itself, you don't feel sick because you have high blood pressure. It's a potential problem. If you have high blood pressure, you have a higher risk of getting a stroke or a heart attack. But it's not making you symptomatic, but we got to treat it in order to prevent bad things from happening. Same with osteoporosis. Osteoporosis per se doesn't cause symptoms. Some people don't understand that. They come in, they think osteoporosis hurts. It doesn't. Osteoporosis is just a condition. It means your bones are thin. But it predisposes to having fractures and things like that. Same with high cholesterol. So the goal of the physician then is to find these things, or the health system, is to find these things, prevent them, and then this person lives happily ever after. If you do this, if you aggressively do this with people in their 80s and 90s, you're going to be diagnosing and treating all the time. And as I said before, that can lead to more harm than good. So my model for the old person would be that for the elderly, with rare exceptions, if there is no problem, there is no disease. What you treat when you are a physician or a nurse or a healthcare worker with people in their 80s and 90s is you treat problems. And if they don't have a problem, neither do you. You don't look at their cholesterol because you don't know how to interpret it. I wish we didn't look at blood pressure because we seem to interpret it wrong in people in their 80s and 90s. And so you wait for a problem, and then what happens if you have a problem? Sometimes the best thing to do is to diagnose when you have a problem. Someone has belly pain, and maybe they get an endoscopy, and we find out they have an ulcer. That's the way it normally happens, right? Another way of doing it, if they're 83 and they're frail and you don't want to send them to some clinic where they're going to have to get awful things and have a tube stuck down their throat and all that, is you give them a pill for ulcers. You think it's an ulcer, you give them a pill for ulcers and they get better. You say, you give them treatment first, and if they get better, you say, hey, I think I know the diagnosis. It's called therapeutic trial, so you don't even do a test. They come in with a bad cough, you don't even get an x-ray, you give them antibiotics, they get better, you say, I guess you had some bronchitis. They come in with belly pain, you give them a protein pump inhibitor. It sounds terribly anti-intellectual. I mean, the whole thing about internal medicine is, I'm talking cave age, methodology here. You're supposed to always understand things and diagnose things before you treat them. But when you're dealing with very old people, that understanding, that old person pays a cost for that. And sometimes the cost is less if you just go directly to treatment in a therapeutic trial, and if it works, you're fine. Sometimes diagnosis is the best thing to do. You go to diagnosis, and that leads to treatment, and then the organism feel better. Most times, of course, the organism is going to feel better no matter what we do. That's the nice thing about being a physician. All right, so that's my message, that I wanted to call into question some of the assumptions we have, some of the assumptions that work very, very well. I do no means do I want you to then start calling into question how to deal with 70-year-olds because they're not old to begin with. But that I wanted people to understand that real old people in their 80s and 90s are different. Some of the things we think we know about them we don't know. And we probably should have a different model, a much more modest model about dealing with them than we currently do. Thanks. Do you want questions from the...
We have time for some questions and discussion from either here or at the teleconferencing sites. Please turn off your have a question and just identify yourself and anybody can hear.
Token question?
Well, I guess I'm going to ask, not being that much into the clinical side of things, but what could be considered one of the greatest challenges for health professionals that maybe don't have resources like we have? We're out in doing this out in the East Texas area, and many times I've heard that they wish that we had somebody else to talk to about what they can do as a multidisciplinary or interdisciplinary type of arrangement. What can they do for something like that in terms of those kinds of challenges?
Well, I think that in the first place, nothing I say will lower the difficulty. The difficulties are exceptionally real. I find that I'm in we're all here in an academic medical center, and everything is very medicalized, and everything is institutionalized, and so we have medicalized home care programs and ACE units and everything like that. That makes up about 8% of the reality of our patients. If we disappeared, it would not be good for our patients, but they would still have 92% of what they need. So I guess the reason I'm saying that is that what I try to emphasize is what are called sort of informal support networks. Often they're not informal at all because, church, for example. I really start worrying when my patients stop going to church. It's like, it's almost as bad as having normal blood pressure when you're old. And so in terms of what you can do, one thing we have to do to a certain extent is lower our expectations of what we can do because we don't understand the elderly as well as we think we do, people in their 80s and 90s. But other, I think, is to really encourage the importance of sort of continuing involvement of family and church. I think there has to be a new set of rules in terms of how we tolerate various conditions. I will occasionally get into struggles with, say, a social worker who might, have done or someone like from, what do you call the Adult Protective Services, because they'll do a home visit and they will see the person living in filth with 75 cats, which apparently seems to worry a lot of people. And I can understand that, or with nothing in the refrigerator. And one of the roles I try to do, and this may be a 92-year-old woman who's lived, by herself for the last 20 years and is beginning to fail, we have to understand the alternatives. That sometimes this is the best that can be done, and maybe the best we can do is try to get the church to come in and help, as opposed to the definitive solution. What's the definitive solution? Get her into a nursing home. Then we don't have to worry about her anymore. Then she's, we've taken care of her. Well, we know what happens when that happens. Bad things happen. So we have to realize often, as healthcare providers, that we're choosing between bad alternatives. We obviously have to know what the values of our patients are on that, but we have to help the families understand that there's no good alternative. Frequently what happens in medicine is people say, do something. Don't just stand there, do something. Well, often with very old people, not doing something or not doing anything dramatic at least, is the better way to go.
Any other questions or comments? Yeah.
One question. Especially in academic centers, younger practitioners, physicians, will believe they are in medical legal trouble if not overdiagnosing and are not comfortable with the quality of life symptomatic approach. Can you let us know your experience in geriatrics, how often we will run into those troubles?
Well, I personally have no, let me see if I can say this. I think, no geriatrician I've ever worked with has been sued. I've been a geriatrician for more than 20 years, and I have run geriatric programs at 4 different places, and this one's pretty big, as you know. It's got like about 10 docs, 11 docs, and unless you haven't told me something, Maria, I don't think that any physician I've ever worked with has been sued. I don't think we've ever been threatened to be sued. There's all sorts of angry people on the inpatient unit when things don't happen, but I mean, in terms of real lawsuits, I am angered by the excuse of medical legal. I think it's a thoughtless, lily-livered excuse for not thinking about what's best for the person. And I must say, when I am given that excuse, I don't tolerate it very well. I try to make the person who has given me that excuse pay a little price for doing it, so that maybe they'll think twice before they give that excuse again, because it is really, it's like a fluorescent light bulb. It's an energy-saving device. You don't have to think to give that excuse, and you can hide a lot of sort of slovenly thinking behind it. But that's not to say I care. No, I do get rather upset when I hear that explanation.
I have one more
Yes.
question. What do you do with the daughter that it just insists that her mother gets such and such? Do you teach? How do you deal with that?
No, I think that's an excellent question. Medicine is practiced in a social context. You know, there is the physician or the nurse practitioner or the nurse, and there's the patient. And frequently there's the daughter. Hopefully there's the daughter or daughter-in-law. And you have to be cognizant of that. And so, for example, I think it's stupid for men over 70 to get a PSA test, and there's no national organization that would recommend it. In other words, the urologists don't recommend it, the American Cancer Society doesn't recommend it. But if I have a 78-year-old man who comes in and says, I want a PSA test, I inform him, you know, that I would not do it because of X, Y, but I do what he asked me. Similarly with, this comes up mostly in my ideas about blood pressure, because I inform my patients, hey, that's cool, you've got a blood pressure of 200, you know, and you're 87, you actually have a much longer life expectancy than if your blood pressure were 140. But as you well know, if you don't treat those people, you're going to get calls from ophthalmologist's office and daughters-in-law and hysterical emergency rooms and things like that. So it's not cynical. It's a recognition that medicine is a social discipline that's practiced in a social context, and you have to do what's socially possible. So with some of my patients, I don't treat. With others, I'll treat. I'll treat a little. You know, if I run into side effects, I'll easily back off, because I know it's probably not a good idea to begin with. But you always want to do what your patient wants, and you want to work it out with the children, obviously, too.
I had one last thing I was thinking of. That's
Yeah?
right. The blood pressure.
No, we had a
I'm sorry,
question.
ask them? Yes?
This is Lamar. I'm Eileen Pearl, and I have a question about the psychological component figuring in the model that you described. You know, we obviously know in the younger populations and middle age that the psychological component is a factor. I'm interested in what you think of the perhaps weighting or the importance of that psychological factor as a person gets older. You talked about some of the physiological indicators
Sure.
are no longer so significant. So is the psychological more significant in
Well,
the older group?
Yes. I mean, we don't talk about psychological components as much in medicine, because we don't feel that we can affect it as much. There's no doubt in my mind that attitude is just overwhelmingly important when it comes to predicting a continued health and survival of older people, and it becomes more important with age. We have good evidence of that. Dr. Glenn Ostier here, who may be talking later on in this series, has done very nice studies showing that so-called positive affect, people who are optimistic, it's one of the major predictors of survival. It's as big a predictor as smoking, except in the opposite direction. So having a positive attitude has as big a factor on your survival if you're over the age of 65 than does cigarette smoking. So yeah, I think it's enormously. I try to interact with my patients. I mean, I try to make them happy, basically. But I think we don't deal with it as much because it's a very powerful observation. It's just I'm not sure many of us are real comfortable that we can influence it. I certainly encourage, as I said before, things like continuing social interactions, things like that that would tend to help those psychological factors. But there's no doubt that it's very, very important the older you get.
Thank you.
Anybody else from the other sites are here? Very good.
All right,
Thank you.